No, wrong thing.
Okay, so let's just take 10 minutes for questions and then we'll go into our break. Is that okay? So if you have questions, if you could write them down and just bring them to the well, let's see, can someone grab them for me? And I'm gonna get all of you guys who just spoke, if we could get you to come on up just for a moment. All you doctors who just spoke, Melissa back up here, Dr. Williams, Dr. Pennington, come on up here. We want to give people a chance to talk and have a seat. And we're going to get going with this. Yeah, I'm going to take the other mic here. Go ahead and have a seat up here in one of the 4 chairs.
And I don't see any online questions, but I have my thing here, so.
Okay, but we probably don't have time for a lot. So, is that one on? Okay, so let's start with, lymph nodes were removed in my back spinal area. Do I have a risk for lymphedema? Do you want to answer that? You want me to pass that to a doctor? All right, sure.
So absolutely, whenever lymph nodes are removed from anywhere, there's a risk of lymphedema. There's pretty good data that basically the more lymph nodes removed, the more risk of lymphedema. I think when you get them done from that area, you don't see lymphedema in the same places. So when you get them removed from the sort of lower veins, which are the ones that we're more typically going for, you see leg swelling. When you get them removed from near your back or spine, you see sort of body wall swelling a little bit more, which can be a little bit more subtle and people just think they're fat or, you know, or bloated or whatever, but you can actually get lymphedema in those areas. And that's actually harder to manage sometimes because the squishy stockings that we use for the other lymphedema, you know, don't cover that area. And so you really have to find a good physical therapist to figure out where your lymphedema is and get you the appropriate gear. And they do make gear, but you have to get it fitted and make sure it fits you and all of that sort of stuff. So.
Thank you. Dr. Pennington, when do you repeat testing for somatic mutations? And how often during a disease, how often during the progression of a disease might you want to repeat somatic testing?
Yeah, I think that's a really good question. I think that is evolving over time and will continue to evolve, especially as we get more therapeutic options. So when we started really doing this, and really testing people at the beginning for both, inherited and tumor mutations, when we tested them later in our own lab, we didn't tend to find very much that was different. But I do think that could change over time. And so I always say when you get tumor testing, first of all, it's always changing, right? There's new things to test for, new things that are being discovered. And so one of the most important things is order it when you might use it. So we get tumor testing at the beginning because if your germline or inherited testing is normal, we use the tumor testing potentially up front. But, if you don't need that, wait, and then later in the course, maybe get it then. So I don't know if they answered the question fully or other people can share different ways. One more thing I want to say is HRD testing, you don't ever need to get again, because HRD, the way it's tested, it's not actually checking for that true deficiency. It's measuring indirect markers. It's like a scar. So if you ever had it, it's always going to show up. So even if someone gets resistance that develops, it's not useful to retest for that later. So I'll just make that special point.
I accidentally clicked answer live and I was trying to answer it on here. Somebody asked, I saw 2 endometrial, 1 uterine and the Acrivon trial in Alaska. Is Acrivon for platinum-resistant ovarian cancer with high folate receptors? And the answer to that is no. It's not looking at the folic acid receptor. It's looking at a completely different molecular target. So there's anybody with recurrent uterus or endometrial could be considered for that trial. And then they're looking for their own specific biomarker. It's not folic acid. I'll do the other one.
Okay, so another question is there it goes. Is there a time frame after completing first-line chemotherapy that the maintenance agent should be started? You want to take that?
Yeah, I'm happy to take that. I mean, so we, we'll typically start it right after, but what you mean by right after probably depends. Sometimes people need a little bit of time, a month or a couple months to recover just from the chemotherapy and for their counts to improve. I always think it's a shared decision making with the patient and what's going on in their lives and when they feel comfortable. But it should be relatively soon after, meaning it may not work as a maintenance drug in the same way if you waited a year and a half to start it. The idea is to kind of maintain the good results of the chemotherapy.
Great. Here's one for you, Shell. How often should I have manual lymphedema, MLD, right? For my lymphedema once in maintenance phase?
That's a difficult question to answer because it depends on your lymphedema. Some people have lymphedema that responds really well to maintenance, like manual lymphatic drainage and compression, and you might do just fine with only coming in every 2 months. And then some have more, say, sporadic inflammation stages where it comes back and goes, and so you need to come in more often. I will say the majority of my clients come in once a month. And then a lot of them will book with me before and after flying, because that can be kind of like something that makes it recur or come back or have an inflammatory reaction. So it really depends on what your lymphedema is, and everybody's is a little bit different.
Okay. Dr. Carroll, I'm curious about the psychological considerations in a giant tumor patient staying at home for so long when clearly there was something wrong.
She was not alone. She was with her husband and her son. There were other people around. She had the whole community around her, her church, her pastor. So it was not like she was alone in this. Everybody was aware. And we did explore that part for herself. And she's a very reasonable woman. And I think it was just unfortunate circumstances with COVID and everything. But yes, we did look at it.
Well, I think it's interesting. I mean, in general, when a lot of our patients come to us advanced presentations with having had symptoms, they don't know exactly what they mean. And it's very easy to say in hindsight, how did we not know something was wrong? And this is clearly a pretty extreme example of that. All right, we got to stop real soon. Going to give you one more. Dr. Hardesty, PARP inhibitor in the first line setting, do you continue to reintroduce it in the second line setting?
That is a good question, and also one where I think that we are still in the process of really learning what's the best thing to do. I think that the answer to that, for the most part, is it's probably not going to give you the same magnitude of benefit in later lines. And a lot of the FDA approvals, for really complicated reasons beyond the scope of this question answer, have been withdrawn. For certain selected patients, if they did, we use PARPs for a defined time period and then we stop them in the first line setting. And so if a patient had a long amount of time go by and then had a recurrence and they were off their PARP, and especially if they were either have a mutation is the definite one, or, had other characteristics that would make us think that a PARP would be a good choice, I have in certain selected patients reintroduced them. And there is some data to support that. But for the most part, most of the benefit that you're going to get from PARP is earlier on in the course of ovarian cancer, in my opinion.
Okay, last question. Katie, can you just clarify a little bit about, just restate, if a mother has a mutation and she has sons?
Yeah, this is a really important point, and I actually accidentally deleted this slide, so I'm glad this question came up. So a mom, remember, you get one copy of the gene from your mom and one from your dad. So a mom could pass that mutation on to her son. Her son does not have an increased risk of ovarian cancer, but still has the gene that then each of his children has a 50% chance of inheriting. So you can, males can pass on these genes to their offspring.
And there are cancers that do impact men that come from the BRCA gene.
Absolutely. So although a man does not have an increased risk of ovarian cancer, male breast cancer, while rare, does happen. And so a BRCA 1 or 2 mutation increases the risk of male breast cancer also. There's also pancreatic cancers and other cancers. So it's relevant for him as well and relevant for his relatives.
All right, with that, I would say let's stop. Let's take 10 minutes, try to be, I know I'm shutting it down just a little bit, but we've gotten behind.